Thank you for joining us on the lightattheend.com podcast. Lightattheend.com is a resource for those who want to learn more about end-of-life topics but don't know where to start. I'm Kevin Berk, and I'm joined today by Dr. Jeff Stoneberg, Medical Director of Palliative Care at Sutter Medical Center in Sacramento. Jeff, thank you for being here.
Oh, happy to be here and talk to you again.
Thanks. Our goal today is to help you, the viewer, understand and feel fully informed and empowered to fill out your advanced directives for yourself or a loved one. Dr. Stoneberg, can you remind us what the difference is between an advanced directive and a POLST form, and whether a person needs one or both of them?
Sure. There's a lot of confusion between the two sometimes. They're similar documents, but they differ greatly in a couple different respects. But I think first we have to understand sort of the greater context of what we're talking about, which is advanced care planning. So that would be just really the practice of trying to understand what somebody would want for their future care if they get into a situation where they can't make decisions for themselves. How do they maintain control of that decision-making process to ensure that they get the type of care and treatment they want and are not stuck in a position that they may not want to be in, but can't tell anybody that they may want something differently done. So that's the greater context of really what we're talking about. Two documents that we most often use are advanced directives and POLST forms. California has a form called a POLST form. It stands for Physician's Orders for Life-Sustaining Treatment. Other states may use the MOLST form. It's Medical Orders for Life-Sustaining Treatment, identical documents for the most part. But there's a big difference between that and an advanced directive. And I often describe an advanced directive to somebody as a document that provides a framework for your family, your loved ones, your decision makers to make decisions for you in a way that's consistent with what your values are and what you want for your own care. If you get into a situation where, you're in a coma, you're on a life support machine, you can't make decisions, but decisions have to be made surrounding your care, that provides direction on how to make those decisions. So I think about that as sort of, what do I want if something happens to me in the future? A POLST form is, if I drop to the floor right now, what do I want done? Do I want somebody to try to revive me, try to resuscitate me and get my heart beating again if it's stopped? Do I want somebody to put me on a ventilator in the short term? Do I want, feeding tubes? It gives you a general understanding of the medical interventions that somebody may or may not want in the more immediate term. So one of the main differences is also a POLST form is a physician's order. So it is actionable. So EMTs will follow it in the field, whereas EMTs are required to try to resuscitate somebody if their heart's not beating, unless they have a form like this that says, do not do that. So it is really a different utility, a different type of form, but they should be sending the same message. One shouldn't be saying, yes, I want to live forever, and the other saying, don't do anything for me. They should be sending a consistent message. And when they start to differ, that means you have to have a conversation and think about redoing one of the documents that's going to be more consistent with what somebody wants.
Okay, thanks, Jeff. Thanks for explaining. So in the absence of having a brightly colored POLST form stuck to your refrigerator, you're saying that the EMTs are going to attempt to resuscitate you.
They will.
Even if that's not what you want. If you don't have a POLST form done, but you do have advanced directives, does it still make sense to attach those with your wishes to your refrigerator or have them visible?
It's not necessary to have your advanced directive readily available on your fridge, or they could be in a drawer. They have to be able to be accessed. They have to be able to be accessed by the people that are going to make decisions for you. Your primary care physician should have one. So focusing a little bit on advanced directives, there's a lot of different forms out there that exist. We talked about 5 wishes, which is a very lengthy sort of document that allows somebody to really walk through a bunch of different questions to really determine what's most important to them. It has things about spirituality. It has things about, psychosocial aspects of their care, medical aspects of their care, what they would want, what they would not want. And again, providing that framework for decision-making, but it's lengthy. And it's a great document if somebody's willing to sit down and to go through it. There are other advanced directives that are very boilerplate. CMS has, here in California, has a very generic advanced directive form. And it basically gives you two options. One, to prolong life, basically at all costs within the general accepted medical standards. So we're not going to do silly things to people or harmful things to people that may result in harm to them or greater or increase their risk or not try to achieve a goal just to extend life. We need to really be thoughtful about that. But if somebody says, yes, choice to prolong life, that means we're going to do our best to try to restore somebody's health to the best of our ability. Somebody checks in the box choice to not prolong life. It usually gives some provisions, like if I'm in a coma and not expected to wake up, if two physicians believe that I will not regain consciousness, then I would want to be kept alive artificially. So it gives a couple of really generic parameters on the CMS Advanced Directive, but that's all that it does in terms of directing your medical care. So it's not very helpful if it's not, expanded upon a little bit. But another thing that the Advanced Directive does that I think is crucial is it allows you to designate a durable power of attorney for healthcare. That is the person that you choose to make decisions for you if you're not able to do so for yourself. So again, if I'm in a coma, who do I want to make decisions for me? Who is that designated person? A lot of people think, oh, it's going to be my spouse or it's going to be, my parent or something like that. And sometimes it's not the best person to have to be in that position, in that role. You need to have somebody who's going to make decisions for you the way you would make them for yourself. Sometimes people have a great deal of difficulty with that type of responsibility and with that having to make that kind of decision for themselves or for their loved one because they think it may result in the end of somebody's life and they may feel guilt around that or sorrow, the emotional component of those decisions is huge. So that person who is the designated decision maker really should be somebody that will make the decisions for you in the way that you want. For example, if somebody is stuck on a ventilator, on a life support machine, and they don't want to live on that life support machine, and those wishes are clearly noted, ultimately that decision falls upon the durable power of attorney, the surrogate decision maker. And if you can't do that, if you can't perform that function in that role, they may try to make this different choices that go against the patient's wishes because of their own sorrow or grief or fear or what have you. So it really needs to be somebody that is going to make tough decisions and work with the physicians and the team in the hospital to make sure we do the right things. A designated decision maker to go to, he makes all the difference for us because now we know who the decision maker is. There's no question. California does not have a hierarchy of decision makers. So the spouse doesn't have more right to make a decision over an adult child, for example. So there's no hierarchy. Some states do have a hierarchy like that. California does not. So in our state, the person that shows up to the bedside, that is answering phone calls, that is participating, that is showing good faith, for that patient, that should be the person who's favored to make decisions. Somebody's coming in and causing problems and acting in ways that are deleterious to the patient's care, then that person probably shouldn't be the decision maker. So that can be pretty tricky when you don't have somebody designated to do that. Let me give you a real example that I had just this past, I've been seeing the guy for about a month in the hospital. And he's in a persistent vegetative state at this point, very sick. He had a bleed in his brain, did not recover at all. And it is in a vegetative state, and he's going to remain in that state without improvement. He's got 20 siblings.
Oh,
20
shit.
siblings. Yeah.
Wow.
He's married. His adult daughter and his brother were listed as a durable power of attorney under the Advanced Directive. His daughter's the first, the brother's the second, the alternate. And you can imagine what that family meeting looked like with 20 siblings, plus their kids, plus the spouse, plus, grandkids and everything else. Imagine trying to get a decision made in that environment. You're not going to. You have 20 different opinions. And having the daughter designated a decision maker Gives me somebody to call every day to give an update, gives me somebody to ask questions, gives me somebody to answer questions to, and keep them informed. I can't make 20 phone calls a day for one patient.
Sure.
So there's a lot of times where, you have in California, we call it the daughter from New York. In New York, they call it
Right. Yeah,
California,
you'd
right? They
said that
keep
on
them up
our
for it.
podcast. Yeah.
Somebody's going to swoop in and save the day. Then they're going to demand that all these things
Mm.
be done when decisions have already been made, a course has already been planned, and we're moving in one direction, and somebody comes in and tries to disrupt that. If you have a durable power of attorney designated, that goes away. Because I'm not going to listen to somebody who's not the
Yeah.
designated decision maker. They can hem and haw all they want. They can be part of the decision-making process. They're not going to make the decision. Now, if they influence the durable power of attorney to make a certain decision, I have
Yeah.
to go with
Got
that.
it. Okay.
But if I have a document, like an advance directive, that tells me exactly what somebody wants, then that's what I'm going to follow. The durable power of attorney's job is not to make decisions the way that they want to make decisions. Their job is to enforce the document and make decisions that patient wants for themselves. So there may be times when somebody's not acting in that good faith and they're not
Hmm.
following that advance directive. And if that should occur, then I get our ethics department involved, and we may have
Okay.
to take steps to remove that person from that role
Yeah.
and then go to their alternate. So
Okay.
things can be
Interesting. All
done,
right.
but I do not know of a single law case where a medical team has followed a person's advance directive, somebody has contested it and won. Those are legally binding documents.
So if like in the case that you said, if one of the 20 people starts complaining, there's person one and person two are on the same page. If somebody else is threatening legal action or
Mhm.
something, you keep them alive, or else that holds no water with you. You're just like, you're not the
Again,
decision
I
maker.
get a risk team involved in the hospital. It helps with these situations. I may get ethics involved, but I do my due diligence to really understand what that person wants for themselves and how do we follow them. It's impossible to capture every possible scenario as to what's going to occur, right? So I described that CMS Advanced Directive, which is California Medical Society, which is very boilerplate, which is very generic. It allows you to, again, identify a surrogate decision maker. It allows you to give some very, you know, broad-based details about what you want or don't want, but nothing specific really. But it's still a very useful document. But even with something like the 5 wishes, which is much, much more involved, it's not going to predict every potential medical scenario that's going to come up. There's, how many times have families sort of been in a medical situation with a family member and they look back retrospectively and be like, how the heck did we get here? How did this happen? I would have never predicted that we were going to be in this situation. And that's not depicted in their advanced directive. But what the advanced directive does do is it provides what you want to capture is like the spirit of what somebody wants for themselves. Right. So even the 5 wishes, which is very long and involved, is not going to capture every possible medical scenario, but it's going to capture the spirit of what somebody wants. I'll give you another great example. I use advanced directive for myself, for my patients. I use it for my mom, which I'll tell you about in a second. And it's somewhere in between the CMS and the 5 wishes. It's not so long and involved as the 5 wishes, but it's got a lot more useful information than the CMS document does. And it asks questions about how you measure your quality of life. If you're nearing the end of life, where would you want to be? What are certain things that you know that you would not want for yourself? What are certain things that are really important to you? Family, spirituality, So it allows you to understand a little bit more of what somebody wants. But there's one page in that prepare for your care document that I like that's blank. And it says you can write really basically whatever you want to write in this page to help us understand what's important to you. And for example, for mine, I have what kind of music do I want somebody playing in my headphones if I'm in coma? There's all kinds of things you can write in there. I filled out this form with my mom when she was sick. I think I said the last time we met, she had pancreatic cancer. And so she and I filled out an advanced directive. And she knew it's just as important to know what you don't want as it is to know what you do want. So on that blank piece of paper, that blank page in that advance directive, she wrote several things. She wrote, I never want to be on a ventilator. She would accept a ventilator for a short period of time after a surgery, but never wanted to be on one long term. Never wanted to be in a nursing home. She wanted to be at home with my dad and my family. She was definitely afraid of pain. So pain control was really important to her. So we put that in there. She never wanted a feeding tube. These were all things that were sort of her line in the sand that we knew that she didn't want to cross. We didn't want to cross for her. So, but it had all the other things in there about sort of long-term life support and, all the other stuff. But that page in and of itself was really helpful because when we got to a point in her hospitalization and the surgical fellow said, the best possible outcome at this point looking forward is your mom in a nursing home with a feeding tube. And I knew that wasn't even going to happen. But that was enough for me to take that back to my dad and say, Dad, let's look at this document together. Because I wasn't the decision maker. He was the alternative. And I said, let's look at this document together. Here's what they're telling us the best possible outcome is. Here are the things Mom told us she doesn't want. So not she's going to be stuck in a nursing home with a feeding tube under the best circumstances. Probably worse than that if she makes it out of the hospital. But now the expected outcome is no longer in line with what she would consider to be an acceptable quality of life. And so at that point, we knew we were crossing a line and we stopped because of the information my mom provided, not because of any decision that we made on her behalf. She made that decision already. We just enforced it. So that blank piece of paper is really helpful. And you can stop me if I've said this other story before also. There was an elderly lady in San Diego who had suffered a large stroke. She came into the hospital. I met her in the intensive care unit when she came in and she was on life support. She had an advanced directive. She had the CMS advanced directive, again, very boilerplate, not much information. Her niece and her nephew were her decision makers. And she didn't have any other family, kids or anything. And they came in and met with me. They brought the advanced directive. We reviewed it. They produced also a note attached from the patient in their own handwriting. It was stapled to the advanced directive. And it basically said, if I have cancer, I don't want any chemotherapy. I don't want any major surgeries. I would accept radiation if it were to help with symptoms. It's very important to me to be in my garden. That's where I like to be. I want to be at home. And that's sort of how I measure my quality of life to some extent. And it was very powerful because it was in her own handwriting. And we read through that note and it was very clear because of the size of her stroke, she was never going to return home. She was never going to return to her garden where she wanted to be. It said nothing about a stroke in her note. It only said stuff about cancer, but it was the spirit of that note which was able to be captured, and we can apply that spirit to different situations. And so, it was a pretty short, straightforward conversation with the niece and nephew who were wonderful and loved their aunt and didn't want to see her in a situation she told us she didn't want. So probably within about 45 minutes, we were taking her off of life support and letting her go peacefully, comfortably. And they were at her bedside. So these advanced directives have pretty long-lasting impacts on people and on their families. I know for myself, with my mom, without that, I mean, this is what I do all day for a living, right? So I'm comfortable with the situation, and I probably would have been comfortable if I had to make that decision without that advanced directive. But I can imagine a person not in the medical field having to make that decision based upon what other people are telling you, and you're trying to learn what's going on, and you have doubts and questions, without that direction, it is a terribly difficult decision to make. They're having to guess what somebody wants. You don't have that document versus just saying, hey, you already told me what we're going to do.
And that's why you said that you would be comfortable making the decision on your mom's behalf, even if you hadn't had the advance directive done that you worked with her on. You would also have had the discussions prior to that, so you knew what she wanted.
And I knew what she wanted, but having that document is a tangible tool that she provided to me. It just takes the weight off to a large degree, having that document. But you bring up a good point. You know, the documents in themselves are really important, but oftentimes the most important part is the conversation that happens around that document. When you're filling it out, when you're sitting around the table with your family talking about, I remember filling that out with my mom and my dad in our living room back in Pittsburgh and documenting her choices. But the discussion that we had was a lot more fruitful than what I was able to capture on that document. So the discussion that takes place is really important. We have to capture those moments too. So having that discussion in the presence of a physician or somebody can also be really helpful. You know, trying to resuscitate somebody is not like jump-starting a dead car battery, right? There's a lot more involved to it. And the outcomes of which are variable, but overwhelmingly terrible. When I talk to people about their advance directives, about their choices, about their medical care, what's an acceptable quality of life, what are their treatment preferences, what are they willing to go through for a chance at a longer life? A lot of people may respond in a way that says, well, I want to live. Of course you want to live. If you tell me that you didn't want to live, then we're going to have a totally different conversation about what that means and where that's coming from. But people overwhelmingly want to live and they want to have a longer life. But the question is not whether you want to live. The question is, how do you want to live? What's an acceptable quality of life? So I was remarking about, you know, resuscitating somebody's heart, getting it beating again after it stopped, after the person died. Can we bring them back? Get their heart going again. It is violent. It causes broken ribs, punctured lungs, which require other tubes to be put into the lung area to allow them to inflate. It requires toxic electricity, life support machine, tubes down your throat to breathe for you. It's violent. The best way I can describe it is that resuscitation is violent. Hollywood does a terrible job of depicting to us, the people in the community, what it's like. You know, how many times have you watched a medical TV program and somebody's getting resuscitated? They cut to the commercial break, they come back and they're awake and alert and eating a sandwich, you know, and having a conversation with the doctor. That doesn't happen. That doesn't happen. So, you know, the success rate, and a study that looked at all these medical dramas of the 90s, their success rate of resuscitating somebody was like 70 to 80%. It was huge. The reality is it's about 30. So,
Yeah.
and people who survive a resuscitation, there are those that do. There are those that are still very highly functioning and can return to work and their families. Those are rare. The overwhelming majority may have kidney damage, kidney failure, liver failure. They may have brain injury where they've had, you know, not had blood and oxygen to their brain. And that causes them to then require a feeding tube because they can no longer swallow. They may be stuck on ventilators, have tracheostomies, and, you know, they're not leaving the hospital and going back and resuming their normal lives. They're going to some specialized nursing care facility to be able to take care of them, extend their life, but recovery is not going to be an option for the vast majority of those types of patients. So the outcomes of a resuscitation, it's not just life or death. It's either death or it's life with a certain quality of life that's along a humongous spectrum that can be anywhere from the rare returning back to your independent lifestyle without much, you know, impact on your daily life, to something that you're in a vegetative state, never going to wake up again and being kept alive by, you know, machines being fed through tubes. You know, is that what somebody means when they say, I want to live?
Jeff, I'm so glad that you explained that about the misconception based on the way, you know, Hollywood dramas of the 90s particularly
Mhm.
might impact the way people think, oh, well, they'll just resuscitate me and I'll be back to normal. But you're saying that it's not that easy, and frequently there's major compromises that have
Absolutely.
occurred, if it's possible at all.
Yeah, and everybody's got an uncle. Everybody's got an uncle who had a stroke, just like, your mom did. Everybody's got an uncle who had a heart attack and a cardiac arrest and was in a coma and recovered. Everybody's got an uncle who had stage 4 cancer and recovered. So it's really dangerous to compare some one-off, a really unusual outcome and expect that's going to be the same for somebody else. You cannot compare one medical situation to another. You cannot compare one person to another in terms of what their medical course and medical events are. So you really have to look and individualize the care and decision making to the particular patient. But that person who brings up the example of the uncle who also had a stroke and is now fine. Well, their stroke may have been a totally different type of stroke, totally different size, totally different area of the brain. And, that person could rehab that stroke. This person's not awake. They're not going to wake up. How are they ever going to participate in physical therapy? So you can't compare apples and oranges. You have to individualize all those decision-making issues to that particular patient and what's acceptable to them.
That's another really good point. So in filling out an advance directive, it seems like you can either have that notarized or have two witnesses to make that a legally binding document.
Correct.
But you're not beholden to that forever. You can change that and redo it as often as you'd like.
Yeah. I would check with your local and state sort of regulations and laws to see, but by and large, advance directives don't expire. They can be replaced with a new one, and then the new one takes precedent based upon date, right? So if I make decision A and B and C today, and then 2 months from now, I have a heart attack and I say, well, now I'm pretty sick. I want to change my advance directive. I fill out an advance directive 2 months from now. That one now takes precedent and it eliminates all past ones. So, and you're right. You can either have it notarized or you can have two witnesses sign it. And again, this should not be a one-time document. What my advance directive says right now should be different than what it says when I'm 75. Hopefully 80, 85 years old. It should be reviewed with, at regular set intervals. It doesn't need to be reviewed every year, but, every couple of years, it, wouldn't be a bad idea just to make sure that it's still in line with what you want. But it should also be reviewed with any change in health, any change in condition, any big medical sort of event that may have happened. You want to review it and make sure this is still what I want. Because as a medical event may impact your quality of life, your independence, your mobility, you still live at home, you have to live in a nursing facility, then your level of independence starts changing, your quality of life starts changing, and can you adapt to that new quality of life to be acceptable to you? Or is it something that you say, this is not for me, I don't want to keep doing it. So those decisions are going to change with time. So that's why they should be reevaluated, especially with any change in medical condition.
So once you've completed this document or recompleted it, if you've done it in the past, you just need to keep it in a place that's accessible to other people, particularly the people that you assign as your first two medical care decision makers.
Yep. So mine exists here at home. Angela has a copy, has access to it. My dad has a copy, who's the second alternate DPOA, and my primary care doc has a copy of it. And it exists also in my electronic medical record. So it can be accessed by anybody who looks at my chart. Having it locked away in a safe in an attorney's office or filed away in an attorney's office as part of your trust without it being readily accessible is not good to have it there, but you need it elsewhere.
Jeff, I think that unless there's something else you want to cover as far as the advance directive, I think we can probably safely wrap up there. All right. Thank you so much, Jeff, for helping our viewers fill out this form and understand the implications of it.
Of course. Anytime.
That concludes this episode of the lightattheend.com podcast. Before you go, remember to leave a like and subscribe to the channel if you haven't already. To discuss anything we covered or didn't cover on this episode's topic, leave a comment for me or our guest. And if you have an idea for a future podcast episode or someone you'd like to connect us with, please get in touch with us for that as well. For more end-of-life topics, guides, and resources, visit lightattheend.com. And for those who wish to support what we're doing, visit us on Patreon. There will be a link in the show description and on our website. Until next time, take care of yourselves and those around you. Bye for now.